All right, so again, I'm going to go ahead with reading the first question. Please feel free to interrupt and make comments at any time. So our first case is a 74-year-old man who was started on amiodarone 3 years ago for the treatment of recurrent atrial fibrillation. His thyroid function tests were normal prior to starting his therapy, and right now his TSH is a little high. If you have access to the questions, you can see the normal reference ranges at the bottom of the fifth question on the second page. The T4 is a little high, the free T4 is a little high, the T3 is also high, and the TSH is fully suppressed. His thyroid gland is difficult to feel. So the question is, what's going on with the patient, and how are we going to manage this? If anybody wants to participate, anybody wants to make any first initial comments about what's going on and why, please feel free to do so. Well, I mean, I think we will all agree that the patient is hyperthyroid. And obviously, being on amiodarone, that is the likely cause of his hyperthyroidism. Before we go on to discuss the details of the case, let's talk a little bit about what amiodarone does to the thyroid gland. Anybody care to comment what happens when somebody is started on amiodarone, even if they don't develop any kind of thyroid disease? Do the thyroid function tests change, or do they stay the same? And if they change, how do they change? Well, okay. Again, please try to participate, okay? Because otherwise, this is going to be a very boring lecture. One more boring lecture, which you had plenty this week. So when somebody started on amiodarone, the first thing that happens is the thyroid function tests do change, even if no quote-unquote thyroid pathology actually takes place. What happens is within the first few weeks, the TSH will go up. The T4 and the free T4 will go up because the amiodarone inhibits conversion of T4 to T3. The T3 will go down, and if you measure it, which in most cases we don't, the reverse T3 will also go up. And if the patient stays on amiodarone and nothing ever happens, no pathology develops, then after about 3 to 6 months, the TSH usually goes down to the normal range. The free T4 and the T4 remain usually in the upper normal range, and the T3 remains in the low normal range usually. And the patients can stay like that with these types of thyroid function tests for a very long time while on amiodarone. Now, by far the most common abnormality that happens with amiodarone, does anybody know what it is? What is the most common pathology that we see if somebody started on amiodarone?
Hypothyroidism.
Exactly, it's hypothyroidism. Hyperthyroidism is uncommon. Most likely it's hypothyroidism. Obviously, this patient developed hyperthyroidism. Now, what are the causes of how can amiodarone cause hyperthyroidism? What do we know about the different forms of hyperthyroidism in cases of amiodarone?
Type 1 and type 2.
Yes.
Amiodarone-induced thyroiditis.
I'm sorry, say that again?
Type 1 versus type 2, yes.
Yes, and what's the difference between the two?
Type 1 is usually in the background of autoimmunity.
Exactly.
Such as, let's say, if the patient has Graves' disease or nodular hyperthyroidism because of the iodine content.
Exactly.
While the type 2 is sort of a destructive thyroiditis, similar to...
Yes, exactly. The type 1 is an overproductive state, like Graves' disease, like a toxic nodular goiter, like was already said. And basically, the iodine is the driver. The gland is using the iodine as fuel to make a lot of thyroid hormone. And there has to be some kind of predisposition, some kind of autonomy to the thyroid gland by itself, underlying Graves or underlying toxic goiter. With type 2, it's a completely destructive process. The amiodarone molecule is thought to be actually destructive to the thyrocyte. And thyroid hormone basically leaks out because the follicles are broken up, and thyroid hormone leaks into the circulation. So, what are any suggestions of what different characteristics between the two? Like, when do you expect to see one versus the other as far as the amiodarone course is concerned, for example?
Type 1 you see early.
Exactly. Type 1 is usually seen early. And
type 2 usually usually by after 18 months
Yes, type 2 can be seen much later, and it can even be seen after we stop the amiodarone, because the amiodarone molecule is very lipophilic and can stay in the system for up to a year, and you can see a destructive thyroiditis even after stopping the medication. So,
excuse me, doctor. Regarding type 2, the destructive thyroiditis, is it because of interleukins or? How is it? Yeah.
Yes, the amiodarone molecule is toxic to the thyrocyte, and it induces an inflammatory response that causes damage to the thyroid. And you're right, all the inflammatory markers go up. Interleukin-6 has been studied very extensively in these cases, but as well as other inflammatory markers like CRP and ESR, all of those go up. The problem, since we're there, the problem with these markers is this. If you run the statistics, you will see that these markers are statistically elevated compared to type 1. The problem is, although the differences are statistically significant, the two bars overlap so much that the clinical significance, the clinical usefulness of this test is actually very limited. Yes, there is statistical difference, but the actual clinical value, because the bars overlap so much, the clinical value of this test is very limited. Plus, they're not specific to thyroid inflammation. IL-6 and CRP and ESR can go up because of many other reasons. A trauma, some other inflammatory process somewhere else. So unfortunately, they're very non-specific and they're very rarely helpful, almost never helpful to make the diagnosis to distinguish type 1 from type 2. There was a note by Alice about getting an I-123, I'm assuming, scan. The problem with getting a radioactive iodine scan is this. Because the amiodarone molecule is so rich in iodine, thyroid glands tend to be basically saturated with iodine. So if you give radioactive iodine, if you get a positive scan, if there is uptake, then that is great. Then you've made the diagnosis that it's a type 1 versus a type 2, an overproductive state versus a destructive state. However, because the thyroid gland is usually so saturated, there's no uptake even in type 1, because there's no room for the radioactive iodine to go in there because of all the iodine from the amiodarone. So in most cases, a thyroid scan and uptake is actually not going to be helpful because of this factor. There's another nuclear medicine test, a sestamibi scan, the one we usually get for parathyroid glands, that has been studied. There is very limited data to suggest that a sestamibi scan may actually be able to distinguish one from the other. Hopefully, we will be getting more data about this in the future, and it will become a much more useful test. So stay tuned about that. Okay, we talked about inflammatory markers. We talked about the scan. What other tests can we get to distinguish?
The color flow, doctor.
Okay, exactly. The color flow. If you do an ultrasound study, if you see increased flow, that means that it's suggestive of a type 1 and an overproductive state versus a type 2, because usually with destructive states, we don't have that. The caveat here is this. Again, if you see it, great, it helps. But if you don't see it, you haven't excluded type 2. What happens is the amiodarone content can actually suppress the blood flow to the thyroid gland. If you take a patient with Graves' disease, not amiodarone induced, but Graves' disease, and you give them non-radioactive iodine while they're hyperthyroid from Graves' disease, and before the iodine, if you do the Doppler, the thyroid gland lights up like a flow everywhere. The iodine will suppress that flow. So again, if it's positive, great, but if it's negative, it doesn't help.
Got a pink. They were on $7. Can you bring them downstairs?
Well, I just brought them upstairs.
Could you please mute your microphone if you're not participating?
I'll give them to the dogs.
Could you mute your phone if you're not participating, please? Thank you.
I have a question, sir.
Yes, please.
I have worked for 10 years now about thyroid artery velocimetry, and it's very useful in such a case, because if you take some kind of 50 to 60 centimeters per second velocimetry as a threshold, often, and I rely on Chinese studies, you can make a huge difference between type 1 and type 2. In type 1, you will have increased velocity and low in resistive index, whereas in the second case, you have a less huge amount of velocimetry and the resistive index are far more increased.
You're talking about doing that with the ultrasound machine, with the ultrasound?
Yes, the velocimetry in the thyroid arteries. It's a Doppler of the thyroid arteries.
Yes, absolutely. I agree with you. The velocimetry, yes, absolutely, I agree with you. It's not something that is done routinely, but you're right. If you have somebody that can actually do that, it is one more tool that we can use. But unfortunately, very few radiologists are actually able to do that.
The main issue that normally you have to be trained in Doppler for years before you're able to do such a thing on such a teeny artery.
Exactly. It's a very, very difficult test. Absolutely. Thank you for bringing it up, but it's a very difficult test. You're absolutely correct. All right. Any other comments?
Tell us more about the system EB. How does it help to differentiate the types? Are you able to comment?
Yes, if there is uptake on the system EB, remember the system EB is technetium, it's not iodine. So yes. It has to do with how active a thyroid cell is. So if the thyroid cell is alive and active, it will take up the technetium even if it is fully saturated with iodine. But if it is a destructive process, so the thyrocyte is dying, it will not take the radioisotope. So it's as simple as that. So if it's a type 1 and the cell is alive and overactive, it will take it up and you're going to be able to see it on the scan.
Is that reliable?
I'm sorry, go ahead.
Is that really reliable? Like if you don't see the increased uptake, can you really still definitively say it's a type 2 and not a type 1?
I wish I could say yes to that, but as far as I'm aware, there's been only one study with about 50 patients. That looked at this. I hope there will soon be another study with more patients to confirm this result. If you don't have a choice, you can certainly use it. But remember that you're going to be basing your decision on extremely limited data.
Sir, can we measure interleukin-6 and others in the lab to help differentiate? Are we able to measure them?
Interleukin-6?
Yes.
You can measure all the inflammatory markers, including interleukin-6. And you're right, in type 2, it will be higher than in type 1.
Yes.
But again, the problem is the differences. If you look at the studies, they do report a statistically significant higher value of interleukin-6 in type 2. Unfortunately, the values, the ranges in the bars overlap so much that the actual clinical utility is very limited.
Yes,
if you get a very high value and you know there's no other source of inflammation in the body, you can say, okay, this is most likely a type 2. But in most cases, there's such significant overlap that, and even though the quote-unquote statistics prove that it is helpful, it's actually not very helpful from a practical standpoint.
Do you use sometime 24-hour urine collection with iodine in order to monitor the decrease in the iodine content of the in link with the overload of iodine?
You can. The problem in case of amiodarone, as I said, amiodarone is a very lipophilic molecule, and it stores. There's huge deposits in the adipose tissue. So you can detect excess iodine and the amiodarone actually molecule itself even up to a year after you stop the medication. So the body is fully saturated with iodine for over a year even after you stop the medicine. So measuring iodine, it's not going to be particularly helpful to see, at least with the initial diagnosis. Yeah, it's going to be helpful to see when the body cleared the iodine, so you know the thyroid gland will be set back to normal. But to make the initial diagnosis is usually not going to be very helpful because you know it's going to be high. And stopping the amiodarone for a day or two is not going to help because the molecule stays in the body for a very long time. Does that help? Does that answer your question?
Yes, my question was dedicated more for the follow-up, but anyway,
yes. Again, you know, we'll talk about the management. I will give a guidance about how to follow these patients. But in the very long run, the answer is yes, it can help. Okay, so let's say this patient gets a Doppler, gets an ultrasound study, has a little bit of flow, nothing significant, and the inflammatory markers are not very helpful. How are we going to distinguish one from the other, and how we're going to treat them? Let's say the patient, clinically, the patient is relatively okay, stable, but he's got, some palpitations because of his atrial fibrillation. He's hemodynamically stable, but the cardiologist is asking for help. And the first question they're going to ask you, do we need to stop the amiodarone in this case? Can you vote in the Q&A or in the chat about yes or no, who would stop, if you want to stop the amiodarone or not? Okay, one answer is if we can, it will be preferred, and there's another answer, another two answers that say no. Okay. My answer would also be actually no, for the following reasons. Number one, the heart is a lot more important than the thyroid. Somebody can live without a thyroid gland, but they cannot live without a heart. So we have to allow the cardiologist to make the determination about whether the amiodarone needs to be stopped or not. That's from an overall point perspective for the patient. Now, when we look at the thyroid gland, the answer is again no, because it will likely not make any difference. The amiodarone molecule stays in the system for so long that stopping it is not going to make much of a difference in the next 2 or 3 weeks about how we're going to manage this patient. Plus, as I mentioned in the beginning, the amiodarone molecule blocks the conversion of T4 to T3, of the prohormone to the active hormone. So if you stop the amiodarone and the levels drop even a little, in theory, there can be more conversion of T4 to T3 and things can become worse. So we can manage the hyperthyroidism separately from the heart issue, and we almost never tell the cardiologist that they have to stop the amiodarone. It can be stopped, but it's not usually it's not going to help very much. So does that answer the question? Anybody has any questions about that?
Yes, I have a question concerning Castran. In order to make us to get rid of the thyroid hormones through the break of the enterohepatic cycle.
Yes.
And we use a lot this drug in Europe.
Yes.
Because it's very effective. Do you use this in US? Okay.
Absolutely, we use agents that bind levothyroxine in the enterohepatic circulation. It's a good way to eliminate some of the excess levothyroxine in the system. Absolutely. Can I tell you that I think it's the mainstay of treatment? It's certainly one of the things that we do. Absolutely, yes. It's a very good medicine and it works very, very well. Just remember that it will not only bind the levothyroxine, it can bind to other things, so be careful with other medications and supplements because you can affect those as well. All right, so how are we going to treat if it's a type 1? How are we going to treat if it's a type 2? If it's a type 1, it's an overproductive state. It's like the background of Graves and toxic goiter. So we're going to treat it with antithyroid medications. Besides the biosequestrants that we just mentioned, we're going to use methimazole, carbimazole, propylthiouracil, whatever is available, and we're going to try to treat it. What is the characteristic response of a thyroid gland that has type 1 amiodarone-induced hyperthyroidism? How do thyroid glands respond in these cases? Usually, a thyroid gland is resistant.
Late response?
Exactly. It takes a much longer time and higher doses for the thyroid gland to respond. The average Graves patient will need 5, 10, 15 milligrams of methimazole and it will respond very quickly within a few days. The Graves, the type 1 hyperthyroid patient from amiodarone will require 20, 30, 40 milligrams of methimazole, and usually they have to be treated for like even up to a month for you to see a difference. So it's higher doses and longer time. These thyroid glands are resistant to the antithyroid medications, although they will work. What about type 2? How would you treat type 2?
Steroids.
Steroids, exactly.
But I have a question.
Yes,
how long would you treat with the steroids before deciding it's a steroid failure, especially if you have you know that there can be mixed types, so you can never be certain that it's type 2. So
Exactly.
if you treat with steroids, how long do you wait before you decide, well, it might actually be type 1 and I'm going to go and use methimazole?
All right, let's talk about the steroids first. Usually we start at a dose of 0.5 to 1 milligrams per kilogram of body weight. And you would usually see a response within the first 2 weeks. Because of the point you made is a very important point. Because it is sometimes extremely difficult to distinguish one from the other, it depends on the situation. The more acute the situation, very often what we end up doing is we actually starting both. We're starting both methimazole and PTU and antithyroid medication, methimazole, PTU, or carbimazole. And you monitor the patient and you see if they respond in the first 2 weeks. If the thyroid function does respond in the first 2 weeks, then we say, okay, this is likely a type 2 because the steroids, this is a response, early response to the steroids. So we stop the methimazole. If the patient doesn't respond, then we start tapering the steroids and continue with the methimazole. But often enough, I would say in my case, in my personal experience, in most cases, we start with both and see how the patient responds and then decide which one we're going to stop. How do you do it?
Well, I have very limited experience, but I think I started with steroids. Okay. And when there was no response, I then decided to add it was carbimazole. Okay. That's what I have.
Yeah. Now, there have been a couple of reports, and I've seen a couple of cases where the situation is quite dire. Like the patient has very poor cardiac function because of the hyperthyroidism that can be quite severe. And, you know, the ICU team and the cardiologist says, you got to do something to fix this. We got to get rid of all this excess thyroid hormone because we cannot treat the patient with it. So you need more immediate and acute treatment. Any suggestions?
The binder thing you're talking about, like cholestyramine?
Yeah, definitely you can do that. That's something you can do. We have had a couple of cases where the patients were so sick that we ended up giving them the best supporting measurements with both the methimazole and the steroids and beta blockers as tolerated. And our surgeons were brave enough to actually take the patients to surgery because we sacrificed the thyroid gland. And I've seen patients with you know, an ejection fraction of 15%, and acute heart failure going to surgery and actually doing well if the surgery and the anesthesia team is experienced enough and problem solved within a couple of hours. Another very extreme measure that I've seen once applied in my life is the use of what we call
cyclophosphamide.
I'm sorry?
Cyclophosphamide.
I'm sorry, you're breaking up. Can you repeat that?
With chemotherapy agent, cyclophosphamide. No,
not cyclophosphamide. Hemoperfusion, basically a kind of dialysis, charcoal hemoperfusion. It's kind of a dialysis that can filter out excess thyroid hormone. Obviously, the effects are transient. You can do that for maybe 2 or 3 days. Like if you can lower the levels of thyroid hormone enough that the surgeons maybe they feel a little bit safer taking the patient to surgery. I've seen it used once, but it has been described in the literature. There was a question about if I can talk about the steroids again, the dose of the steroids. If we usually start at a dose between 0.5 and 1 milligram per kilogram of body weight. But stopping the amiodarone in type 1, in any type of hyperthyroidism, amiodarone-induced hyperthyroidism, if you stop the amiodarone, there's a concern because amiodarone blocks the conversion of T4 to T3. If you stop it and the levels in the blood drop, then there will be more conversion of T4 to T3, and the hyperthyroidism, the clinical manifestations of the hyperthyroidism can become worse, at least in the short run.
We have beta blocker then, or?
Yes, if the patient can tolerate it. Yeah. I'm sorry, go ahead, say that again.
As you said, it could get worse then, right?
Yes.
So could we anticipate this by giving beta blockers to, block the conversion then? of
Yes.
T3 to T4?
Absolutely.
In such situation.
If the patient can tolerate a beta blocker, it should be used. Yes, absolutely. No questions asked. Yes, beta blockers are very effective medications. They help you a lot. Yes.
What about, doctor, changing to another medication such as dronabinol or something that does not affect? Does it really help? Do you think it will help?
You mean switching the amiodarone to something else?
Yes, yes.
In the long run, maybe.
Yes.
But in the short run, to deal with this episode of hyperthyroidism, it will not have any effect.
Yeah.
Because the amiodarone, again, is very lipophilic. It stays in the system for so long that it doesn't make any difference.
How long would you continue this? How long would you decide to continue the steroids before deciding there's no response and stop it? So like you said, that if you start with both and there's a response, you would stop the methimazole. But if there's no response, do you stop it? There's no response to the steroids.
I start tapering the steroids over the following 2 weeks, and hopefully by then I will see the effect that the antithyroid medications will have kicked in, and I will see improvement. So I will leave both for about 2 weeks, and then if I don't see any effect in the first 2 or 3 weeks, I'll start tapering the steroids down and continue with the antithyroid medications. Did that answer your questions?
I think so. If there's a response,
If there's a response early on, then I will probably continue with the steroids and stop the methimazole.
Right, because you wouldn't expect that the methimazole would work so quickly.
Exactly.
Right, but if there's no response, you would assume that it's type 1 and try to taper off the steroids.
Correct.
Okay.
Correct. Yeah. But I will not do it very fast. I will do it over at least 2 or 3 weeks, at least so that I can see that the amiodarone will have started working by then. All right, there's a question. Do you have any experience with sestamibi in amiodarone thyroiditis for diagnosis? Yeah, we talked about that. I have never done it personally. I've never done a sestamibi scan for this reason. But there is at least one study that has described that sestamibi scan can help distinguish type 1 from type 2. Yes. Does Lugol iodine have any effect in type 2? The answer is no. It will most likely have no effect in either case, because the thyroid gland is so saturated with iodine that any additional iodine is not going to help in any way. And plus in type 2, it's a destructive process. So the thyroid gland is being destroyed. So the iodine will have no target, no functional thyroid cell to work with, even if that were possible. But the thyroid gland is anyway so saturated that any additional iodine is not going to help in any way.
And excuse me, doctor, if the cardiologist decided for permanent management for AF, such as ablation, whatever, and the patient, you're still not clear whether it's type 1, type 2, how long will you treat this patient?
Well, I mean, like I said, we will start the treatment with both and see how they respond. If they respond quickly, then I will stop the methimazole and continue the prednisone. I would say usually we continue the prednisone for about 2-3 months, including the taper. After about a month or so, month and a half, I will try to start tapering and see what happens. In most cases, we're able to get the patient off the steroids and the problem doesn't recur. It's highly unlikely that the type 2 will happen again. If it's a type 1, I would continue the methimazole, make sure the patient is well controlled, potentially offer thyroidectomy if it's an option, if they cannot tolerate the antithyroid medications. But I will continue these medications for a long time, long term, even lifelong, if we don't do any other treatment for these patients. And then allow the cardiologist to deal with any cardiac-related treatment separately from this.
Do you think, Dr., PTU is preferable because it blocks T4 to T3 conversion? Does it make sense? Or
yes, it does. It does. It has been reported as having a more significant effect blocking T4 to T3 conversion, and that's why it is the quote unquote recommended medication in cases of very severe hyperthyroidism, whatever the cause may be. But as we all know, at least here in the US, the FDA has put a black label warning about PTU, potential fatal liver damage. So although it's extremely rare, and it's the black label warning is there. What's interesting and funny about this, if I remember correctly, there are actually a couple of animal studies that have used PTU as a liver protective agent. Not that I would recommend it in human in any ever, of course, given the warnings.
But in any case, in the case of amiodarone-induced thyrotoxicosis, amiodarone itself blocks T4 to T3 conversion. So I wouldn't think PTU would be any better than carbimazole.
In that case, you supposedly you want. I absolutely agree with you, but you've got nothing to lose in that case. You have to use a medication. If there's any chance there can be an additive effect of that, it may help. Of course, again, you're taking the risk of the liver damage, but again, like I said, it's a very rare side effect of the medication. But in general, I would agree with you. All right. Any questions about amiodarone before we go on to the next case? All right. So, case number 2. A 72-year-old man is scheduled for carotid endarterectomy for critical stenosis of his right internal carotid artery. He has had 2 transient ischemic attacks in the past month. His preoperative evaluation reveals a FeT4 that is low and a TSH that is 62. So the surgeon is asking you, can I take this patient to surgery, or do I need to postpone the surgery for you to fix the thyroid gland first? So another vote, if you can, on the Q&A about would you stop the surgery, yes or no? Okay, I see a no. May I ask why you would not stop the surgery? I agree with you. Yes, because of a high risk of another TIA or even worse, a stroke. So it's not ideal that the patient will go to surgery being hypothyroid, but we don't have to stop emergency surgery. If life-saving surgery, if somebody's hypothyroid, we can start treating them. If there's any chance that the surgery can be postponed for a few days, a couple of weeks, a month, so that we can treat the hypothyroidism, absolutely, we should do that. But in cases like this patient is having TIAs one after the other, and the next one may be a stroke. We should definitely send the patient to surgery. There was a comment that the patient, we start on 25 micrograms of levothyroxine and send the patient to surgery. I absolutely agree with you. We should start him on levothyroxine and send him to surgery. You remember, if somebody goes to surgery hypothyroid, there's the potential risk is that longer, more difficulty extubating them, metabolic acidosis, longer stays in the ICU in theory. But most patients actually do well. The studies have shown that the statistical differences are very small, if any. But there are very significant changes if somebody is in a myxedema coma state. If this patient is up talking and talking to you and moving around, which is certainly possible with this thyroid function test, it's most likely they will do well even hypothyroid during surgery. And our anesthesia team needs to know that and take that into account. But most of our patients actually do well. Any question about the perioperative management of hypothyroidism? This is a relatively simple and easy question to answer. Okay, so I'm going to go ahead and read question number 3. A 32-year-old woman is referred from her psychiatrist. There's a question. How much levothyroxine you give? So this is for question number 2, of course. That's the debate of somebody who has cardiovascular disease. How aggressive are we with levothyroxine replacement? I would definitely be cautious. Assuming this patient's full replacement dose is something in the range of about 125, 150 micrograms of levothyroxine daily, depending what their weight is. I would feel comfortable starting at something like 50 or even 75. But I don't think there's any specific guide. Some people want to be more conservative and start with a 25 and every week or so go up by 25 micrograms a day until they reach replacement doses. I would start with something like 50. If let's say the full replacement dose is 150, I would start with 50 or 75 and then go up from there. I don't think the patient is at significantly higher risk with that dose versus a 25 microgram dose.
Would you use IV levothyroxine?
Did I answer your question? Do I use IV? If the patient is up about and talking, the answer is usually no. If the more severe, the more sick the patient, the sicker the patient, the more likely I am to use IV levothyroxine, at least while, of course, while in the hospital, just to make sure that he gets a couple of doses in first, doses that I know will go into the system. If am I worried that the patient is myxedematous, then I would certainly use IV levothyroxine. But the average patient with this thyroid function test who's walking and talking, it won't make much of a difference. So only in those cases where I'm very worried for the patient. And again, I'm not doing this because I'm more worried about any adverse cardiovascular outcomes. I just don't think it's necessary. It's cheaper. I don't think it makes much difference.
But postpone the endarterectomy, correct?
I'm sorry?
I don't think you would postpone it,
no,
right?
I will not postpone the endarterectomy. No, I would recommend the surgery take place.
So I mean, if we give levothyroxine, you said 50 microgram.
Yes.
It would take, let's say, a week or so to normalize the TSH. I mean, so
I would say take it. Start first dose today and continue it no matter when the surgery is. Even if the surgery is tomorrow, if the surgery is in a week, just take it and see what happens and go through surgery.
Yeah, I see. Thank you.
All right. 35-year-old woman referred to you because of increasing fatigue and weight gain. Her thyroid function tests include a TSH of 6, PT401, and a T3. These are normal, and a TSH that is 4.3. Her thyroid gland is within normal limits on exam, a little bit firmer maybe. Her TPO antibodies are weakly positive. She informed me that she wishes to be treated with levothyroxine. And what do you tell her, and what do you expect will happen? Again, let's see if we have another vote, if you don't mind. Would anybody treat this woman with levothyroxine?
Case 3 or 4, please?
I'm sorry?
Is it case number 3?
Oh, I jumped one. I'm so sorry. Thank you. Thank you. I'm so sorry. I jumped one. Sorry about that, guys. My apologies. I just realized that. 34-year-old woman is referred to you from a psychiatrist because of abnormal thyroid function tests and increased anxiety. She has been on lithium for 4 months. Her pre-treatment TSH is normal, and she complains of palpitations, dyspnea, insomnia, and increased anxiety. Her T4 is high, her T4 is a little high, T3 is again a little high, and her TSH is fully suppressed. What's going on? Any suggestions, any comments about what's going on with this case? Why is this woman hyperthyroid? And what's the mechanism? Lithium-induced thyrotoxicosis. Absolutely, I agree with you. Can you make a comment about why this woman became hyperthyroid from the lithium? Let's take a step back before we answer that question. Can anybody comment on what is the most common pathology, thyroid, lithium-related pathology for the thyroid gland?
Hypothyroidism.
The most common pathology is actually a goiter.
Good.
An enlarged thyroid gland. It is directly linked to the hypothyroidism you're talking about. What happens is this. Basically, think of lithium blocking the function of the thyroid gland. And when that happens, thyroid hormone levels go down, and the pituitary gland makes more TSH. And that stimulates growth of the thyroid gland. That usually compensates for the blockade that the lithium molecule induces. So the end result is a balance with euthyroidism, but an enlarged thyroid gland to compensate for the effect of the lithium. So the most common pathology that we see is not hypo or hyperthyroidism, is actually a goiter. The second most common, because sometimes the thyroid gland cannot compensate enough despite the formation of the goiter, is indeed hypothyroidism. And the third thing that we see occasionally is hyperthyroidism. So what is the cause of hyperthyroidism in this case?
destructive thyroiditis, maybe?
Exactly.
I'm speculating.
Exactly. No, you're absolutely correct. It is by far the most common reason for hyperthyroidism is the same, is a similar type of destructive thyroiditis. Exactly. You're absolutely correct. The lithium molecule induces an inflammatory response, causes a destructive thyroiditis, thyroid hormone leaks out of the thyroid gland, and the patient is hyperthyroid. How do we, there have been cases of Graves' disease that has been diagnosed at the time of lithium administration, but you know, it's very hard to know if these cases were going to develop anyway, or somehow the lithium triggered these events. But there have been cases of Graves-induced Graves-related hyperthyroidism that have been associated with lithium. In this case, how would you distinguish one from the other?
Thyroglobulin.
How would thyroglobulin help you?
Did you do a scan, an uptake scan?
Exactly. A radioactive iodine scan in this case will most likely work. The thyroid gland is not saturated with iodine. So if you do a radioactive scan, hopefully you're going to see uptake in type 1, which is very rare, and no uptake in type 2. So the scan in this case is usually helpful. Okay, so we did the scan. There's no uptake. We assume it's a type 2. We assume it's destructive. In this case, we don't call them type 1 and type 2. Again, the same question like the cardiologist. The psychiatrist is asking you, do I need to stop the lithium for this?
No, because if it's destructive, it would be self-limiting, wouldn't it?
Exactly. In these cases, lithium-induced hyperthyroidism, destructive thyroiditis are very self-limited. So we don't have to stop the lithium. It's a decision that the psychiatrist has to make based on the psychiatric factors, not because of the thyroid function test. These episodes are usually mild cases of hyperthyroidism and mild cases of thyroiditis that we will resolve on their own without any treatment. Sometimes we may provide supportive treatment with a beta blocker if needed, but almost never steroids, almost never any other kind of treatment. And these cases will resolve, so we do not have to stop the lithium. How likely is for, let's say this episode resolves, the patient stays on lithium. Are they likely to have another episode? Should they be worried about another episode? The answer is usually no. These episodes, if they happen once, and it's extremely rare that they would reoccur, even if the lithium therapy is continued. Of course, if we're dealing with the hypothyroidism, just put the patient on levothyroxine, which is a lot easier proposition. But in these cases, it's usually very mild cases of hyperthyroidism that may require some supportive care, but that's pretty much it, nothing else.
How does lithium induce hypothyroidism, please?
Lithium induces hypothyroidism. It interferes with the metabolism of iodine in the thyroid cell. It can block both the uptake and the organification of the iodine. So it will cause a state of hypothyroidism in that way. And that's why, you know, the pituitary gland makes more TSH that leads to the goiter formation. Any other questions about lithium? Okay. So I'm going to go over the fourth case I've already read. 35-year-old woman with increasing fatigue and weight gain. T4 is normal. Free T4 is normal. T3 is 4.3. Her thyroid gland is normal on exam, maybe a little firm. Weekly positive anti-TPO, anti-thyroid peroxidase antibodies, and she wants to be treated. Anybody would treat this woman? Would anybody give this woman levothyroxine?
Not now.
No.
Well, there is one case where I would actually think and potentially treat this woman with levothyroxine if she told me that she is or she's planning on becoming pregnant in the near future. In that case, I would definitely treat her with levothyroxine because her TSH is 4.3 and she has TPO antibodies. So in that case, yes, I would give her levothyroxine. Otherwise, I would not. Why would you not treat her? Let's say she's already had 2-3 kids, she doesn't want to have any more. Why would you not give her levothyroxine?
Well, for one thing, you would want to repeat the test because it might become normal. She could be a mildly hypothyroid phase of a subacute thyroiditis. That's one reason.
Yes, absolutely. That is critical. In all of these cases, before I have the discussion that's going to take, I'm going to keep my patient for over an hour in my office. I always tell them that we need to repeat the blood test, and I pray that the repeat TSH comes back normal. Because in that case, it's a lot easier for me to prove to her that she does not need to be treated. And you know what I'm hoping that I see on the repeat blood test is either a TSH that is 2.5, or a TSH that is 10, because those are clear-cut indications of what I need to do. In one, I don't treat. In the other, yes, the patient needs to be treated. But let's say the TSH comes back the same. How are you going to have the discussion with her about not treating her? How are you going to explain to her that she should not be treated?
Well, it will be very difficult because with her fatigue and weight gain, very likely, I would prescribe some levothyroxine.
So you think you would treat this woman just to see if it helps?
I don't think it will help, but you know, I've been in this situation, and when the patient wants to be treated, I mean.
Yeah. Listen, I agree with you. These are, like I said, these are, as I'm sure we all have these discussions with our patients in our office, and they can be very long and very difficult discussions. What I tell my patients is this: the symptoms of fatigue and weight gain are very non-specific symptoms. In theory, they could be related to the thyroid gland. There has been absolutely no studies that have shown that if you take somebody with a TSH of 4.3, put them on levothyroxine and take them down to TSH of 2 or TSH of 1, there's actually any benefit. When in the few studies where they tried to do placebo-controlled studies, it was impossible for the patient to know whether they felt better, and whether whether they were on the levothyroxine or the placebo. So there's absolutely no data to suggest that she's going to get any benefit. And there are many case reports where people go on the levothyroxine, and most likely because of placebo effect, they come back and tell you in 3 months they feel better, that levothyroxine is helping, but by 3 to 6 months to a year out, all that benefit is gone, and they keep asking for more and more higher doses of levothyroxine because the effect is no longer there. So I would do my best not to treat this patient. Can I tell you that I have never treated somebody like that? No, I'd be lying to you. I've also had patients who I've treated, but I do my very best not to treat cases like this. And I try to tell them that this is potentially a lifelong treatment, and that's most likely not going to help. Any questions about these cases? About this case, about case number 4?
Well, sorry, not quite that case, but what if the T4? What if you have a slightly high TSH and the T4 was not normal, but the T4 was slightly low? Might you be thinking of central hypothyroidism? Because you can sometimes get the TSH slightly even higher. And I'm asking that because the T4 is 1.1 and it's towards the lower end of the range.
Yes,
I think.
Like you said, the first thing that I will do is I will repeat this. If I get another load, if the 54 normal 54 in our assay is from 0.8, I think. If the 54 is 0.7, 0.8, I would not think of central hypothyroidism. This wouldn't be my first thought. If the 54 is 0.2, 0.3, 0.4, and the TSH is 4.3, then yes, I would definitely think of central. If I repeat this blood test 2 or 3 times, I see the same results, and the 54 being 0.7, 0.8, the TSH being 4.3, 4.5, and the patient keeps complaining, yes, I will think of central hypothyroidism at some point, but honestly, it will not be my first thought.
Do you use? Sorry, go ahead.
Go ahead.
No, I was saying a related question, because I see this a lot from psychiatrists. They start patients on SSRIs or antipsychotics, and you typically get a pattern of a normal TSH and a slightly low T4. Same pattern that you sometimes get with anti-epileptics, and the patients actually complain. So I never know, is that true central hypothyroidism induced by the medication, or is it an assay?
I don't think it's an assay issue. I think these changes are real. Now, whether these changes are actually associated with actual clinical disease, that's very hard to know. I don't think there's any study that has ever shown that. And this is where your clinical judgment has to come in. If there's no other option, you know, the psychiatrist thinks these medications have to continue and we don't have any other option, you can try treating with levothyroxine to see what the benefit might be. But that's a clinical judgment call. Unfortunately, there's no, as far as I'm aware, there's no test to show one way or another, so to distinguish between the two.
Is there any utility for total T4 in these situations? Because my understanding is that a free T4 sometimes is not a very reliable assay.
Absolutely. Depending on the free T4 assay, often enough, free T4 assays report frequent lower values. We've had one at MGAs that often, you know, we saw free T4 that were lower than we would expect. So yes, in that case, measuring a total T4 together with a thyroid binding globulin to get a different type of picture of the thyroid axis, that's absolutely a good idea. Yes. Again, remember that the T4, the total T4 assay has issues. You know, low protein, low albumin, low TBG, thyroid binding globulin, all those things. Or if somebody's on estrogen, they can raise TBG, thyroid binding globulin. Make sure you take all those factors into account. But yes, absolutely, a total T4 will help in these cases.
Can I ask a quick question about lithium-induced
yes.
thyroiditis?
Yes.
Do you use steroids in such cases?
Very, very, very rarely. It's very rare that the lithium-induced hyperthyroidism is severe enough that requires that kind of treatment. There have been case reports, but in the vast majority of cases, these are self-limited episodes that don't require any steroid use. In most cases, a little supportive care with a beta blocker or even nothing sometimes is more than enough. So
but the hypothyroidism you would treat, though, the lithium-induced hypothyroidism.
I would treat them with levothyroxine, not steroids.
Yeah.
Yes, absolutely. Yes, absolutely.
Can I ask a question that's a little off topic?
Yes, please.
So in my practice, I find a lot of referrals with other providers checking free T3 instead of total T3.
Yes.
And that could be in the setting of hyperthyroidism or hypothyroidism. I feel the T3 is not useful in the setting of hypothyroidism, but can you comment on the use of free T3 or total T3 in the setting of hyperthyroidism? In my training, I was always told that free T3 is not as reliable.
That is absolutely correct. The free T3 assays are very bad assays. They're not reliable at all. Obviously, if you're thinking about hyperthyroidism, some kind of measurement of T3 is absolutely necessary in order to make the correct diagnosis. But the free T3 assays are what we call very unreliable assays. It's unfortunate, but they have not been studied well. I'm sorry, they have not been developed enough to make them reliable. So I would not measure free T3 commonly, routinely, I would say. The few cases where I actually measure free T3 is if I have thyroid function tests that I don't understand, that don't make sense. I have a case right now who had that patient that has completely normal TSH, completely normal total T4, total normal T3, and high free T4 and a high free T3. So those are the cases that are, you try to get as many tests as you can to try to make some sense of it. But in the most part, I would never use the free T3 assay, only the total T3 assay.
Thank you.
Just to make a comment there, I have seen cases, and I'm sure you have too, where the patient is a young woman with a normal TSH, normal free T4, and a high total T3, and that's simply because they're on a birth control pill. And they send them to me for hyperthyroidism, and there's absolutely nothing wrong with them because they simply are on the birth control, which raises TBG. So just be aware of those factors, which I'm sure everybody is. So there's a question in the system. Is there any role for the use of lithium in somebody who's intolerant of thiamides to treat Graves' disease or a toxic nodule and is not a candidate for surgery? Oh boy. The answer is there have been studies that looked at lithium as treatment for hyperthyroidism. Very limited data. It can help. My understanding is that the problem with lithium is that reaching that magical therapeutic level is very difficult. And in order to treat hyperthyroidism, it's very, very difficult to keep that magic, to keep the dosing at that magical range where the patient will stay out of trouble and not have lithium toxicity. And that's why it's not a treatment that is commonly used. Personally, I've never used it. But yes, you're absolutely correct. There have been case reports, there have been studies that looked at lithium as a treatment of hyperthyroidism, but very, very, very rarely used. Okay, there's another comment for the third case. Can we hold the lithium before? No, we don't have to hold the lithium before scintigraphy. I don't think so. No. Can you comment on the low total T3 and TSH? I'm sorry, I don't understand this question. Can you comment on low T3 and TSH and free T4 normal? So you have a case that has a low TSH and low T3 and a normal free T4? Is that what you're asking? Okay, low TSH, low free T4. I mean, if the T3 is low and the TSH is low and the free T4 is normal, and these levels are repeated, and they're again like that, then I will start to think about central hypothyroidism. I will start to think about maybe something is wrong with the pituitary gland. I would want to make sure there's no reason for the low T3, like low thyroid binding globulin or something like that, liver disease. But yeah, I mean that's with these thyroid function tests, I will start to think about the pituitary gland. In your experience, how do you prepare a patient for thyroidectomy and hyperthyroidism in case of neutropenia and this with methimazole? Excellent question. Let's say the question is if somebody is hyperthyroid, you put them on methimazole and they develop neutropenia, which is rare but not impossible. And the neutropenia is severe. Obviously, you have to immediately stop the methimazole. There's no question about it. What I would do in these cases, I would start the patient on cold iodine, non-radioactive iodine, SSKI, Lugo solution, whatever is available to you. In the short term, in the short run, it's a very effective method of controlling hyperthyroidism. It will decrease blood flow, it will significantly lower thyroid hormone levels, and the patient will be able to go to surgery safely without any problems, together with beta blockers, all the supportive measures, steroids if needed. But I would give them as non-radioactive cold iodine, SSKA or Lugos, to control their hyperthyroidism. Remember, if you start this kind of treatment, the problem here is that in theory, if you keep going for a long time, several months, you can escape from the Wolff-Chaikoff effect, from the blockade of the radioactive iodine, and you can go into the other side. The iodine you gave them may make things worse. So I would say that if you start the iodine treatment for cases of hyperthyroidism, it is a really, really good idea for your patient to actually end up having the surgery. Because it's certainly possible that if the patient doesn't have the surgery and they cannot use antithyroid medications, their hyperthyroidism may become much worse after a few months. Any other, did I answer that question okay? Any other questions? Any other questions about it?
I have another weird case that I've recently seen. It's okay. All right, patient was referred to me. I think she's probably like 30s, 40s or something like that. And she had 2 sets of thyroid labs that were done before she was referred to me. She has had a TSH in the 2s range and a free T4 like 0.65, 0.7 twice over the course of a year. And so she was referred to me for central hypothyroidism and thinking she has central hypothyroidism. So I do her full PIT panel. And the TFTs that I get back, her TSH is 4.2 and her free T4 is 0.8. All her other PIT labs are normal, except for an undetectably low ACTH, an 8 a.m. cortisol of 19. So at this point, I'm like, wait a minute. Now I'm looking at like adrenal Cushing's, which is completely separate from what she presented with. Anyway, I do a DST. It was normal. At this point, I'm like, okay, well, what do I make of the initial labs? I wondering what you would do in this case. What I did was I just went ahead and sent her for an MRI, which I'm waiting on results.
I don't blame you for making that choice. I would probably make the same choice myself, because the last thing you want to do is miss a pituitary tumor.
Okay, great.
I would absolutely agree with you. In these cases, you don't have a choice. You don't want to miss something that can be critical for the patient. So I would definitely do that MRI too. I don't know that I would treat the patient with thyroid hormone. I would. Is the patient symptomatic? Is the patient complaining of anything?
I have to go back and look at my notes and see what symptoms she was having. Plus or minus, I can't remember.
I mean, particularly if she's asymptomatic, she's not interested in having kids anytime soon, I would not rush to treat her.
Okay.
I would follow, make sure, see what the MRI shows, but I would definitely follow those thyroid function tests and reassess that totally suppressed ACTH. Again, remember, with the ACTH, sometimes it's a lab error. It has to go nice right away. Make sure the phlebotomy team knows exactly how to draw an ACTH. But if that's not a factor, then you need to assess it further. Absolutely agree.
Appreciate it.
Okay.
Doctor, I have a question, please.
Yes.
As a trainee, we face lots of patients coming with this question regarding COVID-19 vaccination.
Okay.
Does it affect thyroid function?
Okay.
COVID, I know that it has this effect, but does this COVID-19 vaccination, such as Pfizer, Moderna, etc., as always patients, they say we have deranged thyroid function, or my thyroid got worsen after this vaccination. Is this true, or what are your comments, please?
My comments are that obviously the most accurate comment that I can tell you is that we don't know. But having said that, there have been case reports and case series of thyroiditis developing either after getting COVID or getting the COVID vaccine. So is it possible to have thyroid function abnormalities after COVID, after getting COVID or getting the vaccine itself? The answer is absolutely yes. It has been described. It's not a common effect. Most people who didn't get the vaccine don't develop thyroid abnormalities, but it is certainly possible. The cases of thyroiditis have been described. So if somebody complains and they have abnormal thyroid function test, they should be managed as whatever the test shows. If there's evidence of thyroiditis, they should be managed as such. So it has been described. It's certainly possible, yes, but not for most people. Most people don't develop any thyroid abnormalities.
Thank you very much.
I have some questions in the chat.
Okay, I'm sorry. In the chat, okay, I'm sorry. How do you dose SSKI? The SSKI, it's usually 1 to 3 drops 3 times a day. Just in my own personal experience, be careful what you mean. Make sure the patients understand exactly what you mean by drops, because not everybody will assume that they're 3 tiny drops. Sometimes they assume the 3 of the entire dropper tube. So be careful. So and you have to warn them that SSKI tastes horrible. So they should be prepared for that. But usually it's about 1 to 3 drops 3 times a day. That's how I dose it. Could you comment on how to proceed when a combined type of amyloid-induced hyperthyroid patient for unrelated reason took corticosteroids and thyroστatics, half recommended dose for a month, and then, okay, I'm sorry. So have an amyloid patient for unrelated reasons took steroids. Please don't remove the comments yet. Don't remove them. Took corticosteroids and thyroid medications. Half recommended dose for a month, and the TFTs haven't improved. Any positive dynamic. If they've taken half the dose of what I would recommend and they haven't improved, I would simply put them on both medications, full doses, and restart the clock. Because I don't know what's failed, the half of the steroid or the half of the antithyroid medication. So I would put them on full doses again and reset the clock. 2 or 3 weeks to see if they respond to the steroids. If they don't respond, then I will continue with methimazole. Possible interfere. There's a comment about possible interfering antibody. I am sorry, the anonymous participant who I thought, I'm not sure what that comment refers to, what part of our discussion. So I would love to, if they can specify, I would love to know what part of the discussion they were talking about, the possible interfering antibody, which is definitely something that happens. Okay. Any other questions? Any other comments right now?
Yeah, sorry. I had two other questions, and it's regarding treatment of patients with antithyroid drugs and Graves'. Not uncommonly, I sometimes see a profoundly low T4, but the T3 is still normal, and
Yes.
the patient is clinically euthyroid, sometimes even clinically thyrotoxic, and the TSH is still suppressed. That's one thing. And a related question: how long after? How can you really tell when you've been treating somebody for several months, their T3 and T4 is low and their TSH remains suppressed? How can you really tell if that's just prolonged suppression or if that's actually ongoing, continuing subclinical hypothyroidism because they're undertreated?
Okay, let's talk about the first case. You said a low TSH, a low T4, but a normal T3. Is that correct?
Yes. Yes, and sometimes a very low T4, but the T3 is high normal or normal.
Remember, what happens, the body is doing its best to keep as much functional thyroid hormone as it can. So even if your T4 keeps going down, the body will still convert it from T4 to T3. So when you block the thyroid with the thyroid gland with methimazole, the body will use all of the T3, all of the T4 available and try to maintain T3 levels. So it's not, it's actually what you're describing is somebody who is blocked on thyroid on antithyroid medications. Their TSH hasn't recovered yet because, as you mentioned, it takes a long time for the TSH to recover. But you've actually made the patient hypothyroid. That's how I read this, because the free T4 is low and the body is just converting whatever free T4 is available into T3 to maintain T3 levels.
So you would reduce the dose of the thyroid?
Yes, in that case, I would reduce the dose of methimazole, yes.
Because what I find sometimes is that you reduce the dose of the methimazole, the T3 goes up and the patient actually has clinical features of thyrotoxicosis. So I'm wondering, do you often see this pure T3 toxicosis where the T4 can actually be quite low? That's what I'm saying. That
was my next comment. If that happens, then you could potentially be dealing with a case of pure T3 toxicosis. And then I agree with you. I will continue with the methimazole to allow for the TSH to come up, and then I will have a much more clear idea about what's going on. Pure T3 toxicosis is very rare, I would say. Graves' disease is usually a T3 dominant picture, but it's not a pure T3 toxicosis. But you're right, it's certainly possible. It's a very rare event. In my understanding, that it's very rare, but it's not impossible. Did I answer your question? Is that okay?
Yes, thank you.
Okay. I thought of another set of cases that it's not infrequent for me to have patients that I treat for hypothyroidism, already on levothyroxine, has had elevated TSH, like it's true hypothyroidism. And when I treat to normalize the TSH, their free T4 goes overtly high. Have you seen this?
Yes, I have. Well, obviously, I'm assuming you're measuring the T3 not in the morning after having taken the levothyroxine, right?
I'm sorry, I didn't hear what you said.
You're measuring the T4, telling them to, if you're measuring it in the morning, you've told them to hold the levothyroxine dose so that you don't measure the T4 at the peak of absorption.
Correct.
Okay. You're right. If you look at the scale between TSH and free T4, it is often the case that we have to give enough in order to give enough TSH, enough levothyroxine to make the TSH normal. Free T4 can go higher, and that's where many of the experts, there's a debate about whether that means that the patient needs T3 on top of the T4. As you know, T3 administration is very problematic, has all sorts of issues with it, and we're happy to discuss them if you want. But the discussion is, are we missing something with these patients? Should we be giving them T3 together with T4 because T4 is not sufficient replacement? I don't think there's an answer in the literature about that yet. Hopefully we'll get it sometime in the future, but that's the issue there sometimes. And what do you choose? Do you choose the normal TSH or do you choose do you lower the dose to allow the free T4 to come down and the TSH to come up, or vice versa? I would probably go with the TSH and see if the patient is clinically euthyroid, but can I tell you there is good data about that? No, I cannot.
Okay, great. I think personally, when that happens, I treat to T4 instead of TSH, but I've only recently learned, like from colleagues, the addition of T3. And so as I see patients back, I think I might start trying that too.
The one case where I would definitely go with the TSH is the cancer patient who needs a lot of.
Sure.
Yes.
Okay.
Yes, thyroid cancer patients.
Yeah, right. You almost done.
May I ask Daniel to mute their microphone if they're not? Thank you. So yeah, in cases of cancer, that changes things, but otherwise, yes. Any other questions?
In which case do you prefer to use a block and replace instead of pure anti-thyroid drug?
That's a difficult question. The question is, when do we use a method of replace, block, in cases of hyperthyroidism, block the thyroid hormone with the thyroid hormone production with methimazole completely and add levothyroxine on top of it. In general, I don't practice that. I would generally think that would be useful in cases where the patient needs thyroid, anti-thyroid medications with methimazole to stay euthyroid, but instead of staying euthyroid, they become hypothyroid. There are some cases, I'm sure you've all had them, where you put them, they're hyperthyroid, you put them on 5 milligrams of methimazole or low dose PTU, and they become hypothyroid, and then you stop it and they become hyperthyroid again. So in those cases, I would put them in, but they don't want to have surgery. I would put them on a good 5-10 milligram dose of methimazole that I know will make them hypothyroid, and not levothyroxine on top of it, just to correct the hypothyroidism. If I want to avoid surgery, that's the case where I would actually do that. I know some experts would do that directly because they find it easier to just completely block the thyroid gland with methimazole or PTU and then add thyroid hormone on top of it. In my mind, I would prefer to avoid using higher doses of medication unless I have to, like with methimazole. So, and I think most patients can be safely managed with just methimazole with stable thyroid hormone levels. But you're right, there are some people who have a lot of very significant fluctuations, and you cannot find a good stable dose of methimazole to keep them euthyroid. And those are the cases that you would think about completely blocking their thyroid gland with methimazole or PTU and adding the levothyroxine on top of it. Does that make sense?
Yes, for me, it's just a matter of different schools, because I come from Europe, in which block and replace is much more used in comparison with North America. That's the reason why I really wonder to know more about your opinion. Thank you.
Our preference is only if somebody has wide fluctuations that cannot be controlled with just methimazole, the anti-thyroid medication, then we will use the block and replace method. Would you use it for every case?
Someone has just opened the micro. Could you just repeat your question, please?
Would you use block and replace in every case of hyperthyroidism?
I have been taught in the east of France during my formation that we were only using block and replace. Because it was, but there is a very important difference. We use a lot more of pure anti-thyroid drug philosophy. That's the reason why sometimes it's more tricky. We just put block and replace. If you use, for example,
Daniel, please mute your microphone. Okay, Mark, please go ahead.
So I just wanted to stress if it depends on the global philosophy. If you use more anti-thyroid drugs versus more radioactive iodine, sometimes it modifies the way you see the treatment in general.
Absolutely, yes. I absolutely agree with you, yes. All right. Let's see if there are any other questions. There's another question. Could you please?
I have a question, please, doctor.
Yes.
If a patient is on levothyroxine and liothyronine, do you use the same parameters to monitor the adequacy of, is it the Same lab test to monitor the
Sorry, say that
adequacy.
the patient's pneumothorax and what else? Say that again.
Liothyronine,
Yes.
LT3, sorry.
Yes.
So you use the same labs to monitor, or
I would, if somebody's on T3, I will measure T3 levels, but I'm gonna be blunt about this. I do it for only one reason: to make sure the patient's not overdosing. You know, often enough, the patients will take a lot more than they should be taking because they think they're going to give them more energy, they're going to lose weight. But that's the only reason why I would measure it, and I would try to tell them to have blood tests done before taking the morning dose.
yes.
But for the most part, I will still depend mostly on the TSH and the 54.
And it does suppress the TSH just like levothyroxine?
I'm sorry, say that again?
Does it suppress the TSH in the same way as...
Absolutely, absolutely.
Yeah.
T3 can definitely suppress the TSH, yes. I have seen a couple of cases from psychiatrists who think the patient's hypothyroid, or they want to treat their depression with T3. They put them on T3, and what they do is they, instead of monitoring levels with TSH, 54, and T3, they just measure TSH and 54. And what they see is they see a suppressed TSH and a low T54, and they give them more T3 because they think they're hypothyroid. And they keep going on this vicious circle, but they never check T3s. And if you check T3, they have a suppressed TSH, a very high T3, and a very low T54 because of all the T3 they're taking. So that's why I would usually measure a T3 in those cases.
Yeah, what I see too, and I have a similar experience, is that they measure the T4 and the TSH. They see that the T4 goes down, and then they add the T4 on top of the TSH of the T3, and then the patient becomes obviously hypothyroid.
Yes, they do that too. Absolutely. Yes, I agree. Yes. All right. There's a question here. Could you please comment if subclinical hyperthyroidism should be treated if the patient is planning for pregnancy, Graves or nodules? Does it matter how low the TSH is to decide on treatment? Excellent question. Young woman has subclinical hypothyroidism and is planning pregnancy. Okay, subclinical hyperthyroidism usually is defined as a low TSH with normal 54 and T3. It depends on the situation. In general, I would rather know exactly what I'm dealing with and treat it, definitive treatment before the woman becomes pregnant. So I would tell them, you know, let's figure out why you're hyperthyroid and let's treat it, whether it is with radioactive iodine or surgery, let's treat it definitively so we won't have to worry about your pregnancy. If she's already pregnant or she doesn't want to wait and they have these types of numbers, then I would tell them, go ahead and get pregnant, and I would follow them. Hopefully we can get through the first trimester without the need of any antithyroid medications. But I would follow the numbers very carefully. When it comes to Graves' disease, remember the antibodies do cross the placenta. So if the antibody titer is high, you have to monitor the baby very carefully, no matter what the thyroid function of the mother is. But in most cases, you know, if a woman gets pregnant and she's subclinically hyperthyroid, nothing bad's going to happen. I am following a couple of women now that have a TSH that is suppressed, a 54 that is high normal, and a T3 that is between 200 and 300. So I just follow them, and they're clinically fine. The pregnancies are fine. Nothing wrong's happening. Nothing bad's happening to them. They don't have hyperemesis gravitarum, and they do well. So most women will do well, and the babies will do well. But if I have the option, I try to treat the hyperthyroidism ahead of time before the pregnancy. And remember that if they have Graves' disease and they deliver the baby, that's when you're going to see the flare-up of the Graves' disease. So you have to follow the thyroid function very carefully after the pregnancy, in the first year, the postpartum year. Any other questions? All right. I am briefly going to go over the last case just to have a brief discussion. 36 years. I'm sorry, go ahead.
Yeah, I wrote a small question in the...
Oh, I'm sorry. Oh, there's more. I'm sorry. Okay. If the TSH is just mildly low, 0.1, 0.4, do you still treat it? No, I would not treat them. No, I would follow them. No. There's another question by Alexa. Is there a degree of TSH elevation with subclinical hypothyroidism with concurrent normal to upper end of normal 3 to 4 that makes you suspicious of resistance to thyroid hormone? any lab assay interference or TSH producing adenoma. For example, I recently asked about an asymptomatic 68-year-old woman for whom the past decade she has had TSH elevation and she has overall increasing, that has overall been increasing, but she has concurrently had mild to upper normal range, mild to mid to upper normal range 54 readings, even overtly high 54 readings with concurrent TSH elevation. TSH 35 with a 54 of 18. I mean, obviously, this is a case where I would start to think about central hyperthyroidism. That's I would definitely look at the pituitary gland in this case. You know, resistance is a much more difficult diagnosis. If you get the pituitary gland imaging and you see nothing, I would try to go back to find TSH values in the past. If have they been normal in the past and now they're elevated, that speaks against resistance. And if I don't have that, I would actually try to get family history. I would try to get, you know, history of family members to see if they have similar thyroid function tests. And if I don't have any answer, then I would consider getting genetic testing, you know, sequencing the TSH receptor and see if there's evidence of any resistance. But with this thyroid function test, I would definitely look at the pituitary gland. You know, I would definitely consider secondary hyperthyroidism. Could it be an assay problem? Yes, it can always be an assay problem. You can try running the same your blood test through a different laboratory that uses different assays. You can check F3D4 by equilibrium dialysis, which is considered the gold standard, to see if you get a different number. This is a case, yeah, you measure the 3T3. And there's also an assay, at least here in the US, there's an available assay about antibodies against T4. You can run that as well, but you see if there's any interference there. If I didn't answer, Alexa, if I didn't answer your question enough, if you need more comments, please let me know. If someone's hyperthyroid and the ultrasound does not show any nodules, is there any possibility that they have taken stent surgery called a hot nodule? The answer is, I found it very difficult. If there is no nodule that you will see anything like that, it's not necessary that the entire thyroid gland will have uniform uptake. There can be cold areas. Let's say when you have an episode of subacute thyroiditis, it's not always the entire thyroid gland that is involved. It's often one lobe versus the other, or even part of a lobe that is there. And those differences are very clearly seen sometimes with the ultrasound. And I don't know if you've had patients where they come in, they say, no, it's the right side is hurting me, or my left side. And then 3 months later, now it's the other side that is hurting me. And if you do a scan, you will see that. So you can have areas with low or high uptake without any ultrasound findings of a nodule, because processes like thyroiditis are not always uniform. Sometimes they are uniform, the entire gland is involved, sometimes not. Sometimes it can be the lobe or part of a lobe. After total thyroidectomy, start of radioactive iodine treatment for papillary thyroid cancer or follicular variant. If unstimulated thyroglobulin was initially undetectable but slowly rising 0.2, 0.5, and ultrasound is normal, what imaging should you order? These thyroglobulin levels, 0.2 and 0.5, I'm assuming you mean with negative thyroglobulin antibodies always. Make sure your antibodies are always negative, because if they are, you cannot rely on those numbers. But if you don't have thyroglobulin antibodies, I am not too concerned about these values. Obviously, it depends on how fast they rose. Also, you know, how quickly they go up. If in cases like this, if this is a true papillary thyroid cancer, and I'll explain what I mean by that, any thyroglobulin will by far most likely be coming in from your neck. So if you're worried about recurrent or persistent disease, you need an ultrasonographer that knows how to look at the neck. The disease will most likely be located in the neck. So that's where you need to focus. You need somebody who can do a really thorough ultrasound study to look at the neck. Sometimes you may find nothing, sometimes you may find something. Now, remember, the problem with the follicular variant of papillary thyroid cancer is that sometimes it is a papillary cancer, sometimes it's not a papillary thyroid cancer, sometimes it can be a follicular thyroid cancer, even though it's described as a follicular variant of papillary. So if you have the option in cases like this to do molecular testing to see if this is a BRAF tumor or a RAS type of tumor, it's going to help a lot to distinguish where you need to look for potential metastasis. If it's a follicular cancer, you don't need to look in the neck, you need to look somewhere else in the body. So it makes things a lot more complicated. But if it is a true papillary, where you need to focus with these numbers is in the neck. If there is something going on, it's by far more likely that we'll be looking at it in the neck, not somewhere else in the body. If a patient is subclinically hyperthyroid for a year and uptake and scan is normal, could we assume this is Graves' disease? If the TSH is low and the uptake on the scan is normal, that is an abnormally normal scan, no abnormally normal uptake. What drives iodine into a thyroid cell is the presence of TSH. If there is no TSH around, then there should be no uptake of iodine in the thyroid gland. If you take an animal, remove the pituitary gland, and do a thyroid uptake, you will see minimal to no uptake because there is no TSH around. So if there is no TSH, there should be no uptake. If the TSH is low and yet there is uptake, something else is driving the iodine into the thyroid cell, whether that's TSH receptor antibodies in Graves' disease or an autonomous nodule, something else is driving. So the setting of a quote-unquote normal uptake between 10 and 30, depending on what your machine gives you as a normal, but a low TSH, that's by definition hyperthyroidism. So that is the case of Graves' disease. Okay. Any other questions? I know it's already 6 o'clock. We're out of time, but I'll be happy to answer a couple of more questions if you want.
Are you able to go through the case really quickly?
Sure.
Is it okay with you, please?
It's fine. And if anybody can stay longer, they're welcome to join us. So the last case is a 36-year-old woman who has a 2.2 centimeter right thyroid nodule, and the biopsy shows a microfollicular lesion, what we call a follicular neoplasm. Here in the US, and I'm sure in most places in the world, we use the Bethesda classification system for biopsies. That's a Bethesda 4 biopsy. And the patient is referred to a surgeon who is recommending a right hemithyroidectomy. Who would send the patient? Would you send the patient directly to surgery, or would you do anything else? Well, it depends on where you practice and how you practice. I would say that if you have the option of molecular testing, which we're lucky enough to have in the US, I would not send this patient to surgery because with the development of the molecular test, we have saved many people the need for surgery. Before the molecular tests are not available, the only option you have is unfortunately a diagnostic surgery, a diagnostic thyroidectomy to try to figure out if this thing is a malignant tumor or a benign tumor. Still more likely to be benign. In most labs, we report a risk of malignancy of about 20 to 40% if it's a Bethesda 4 category. If we have the option of molecular testing, then you should do the molecular testing to try to decide if this is benign or malignant. If you don't, then you're stuck with surgery, unfortunately. So, any questions so far before I go on? So the patient does have a repeat biopsy, and the repeat biopsy shows again the same microfollicular lesion, and the molecular test called the Afirma gene classifier is reported as suspicious. So for those of you who are not familiar with this molecular test, it's a test that is available here in the US, and it's what we call a rule-out test. If this test comes back as benign, as negative, then the risk of malignancy drops to about 4%. So it's a very different discussion. If the test comes back as suspicious, as in this case, it doesn't prove cancer, it raises the risk of cancer to about 50%. So like I said, it's a good rule-out test. It won't prove cancer, but it will rule it out. So in this case, this woman's test came back suspicious, which means the risk of cancer is now about 50%. So obviously, at this point, the only thing we can do is send the woman to surgery. That's the only option that we have. Now, remember, if we're talking about a follicular neoplasm, which means we're talking either about a benign follicular adenoma, most likely, or a follicular carcinoma, a biopsy will never be able to distinguish one from the other. I can do 100 biopsies on this node. I will never get the answer about whether this is cancer or not. And the reason for that is when it comes to follicular neoplasms, the difference between a benign and a malignant lesion has to do with whether there's capsular or vascular invasion. If there's invasion in the capsule, through the capsule, or into blood vessels, that's a cancer. If there is no invasion, that's a benign nodule. And a biopsy will never give you that. In order to know that, you have to remove the entire nodule and you have to section the entire capsule in order to see if there's any invasion. That's the only way you can know the difference between the two. And that's why a single FNA without molecular testing will never be enough. With the molecular testing, if the molecular testing comes back benign, then that gives you more reassurance that this is a benign nodule and you can watch it if you want. So because this woman molecular test came back as suspicious, raising the risk of cancer to about 50%, she was recommended to have a hemithyroidectomy. So she goes in, has a hemithyroidectomy, and the final pathology report is a minimally invasive follicular carcinoma with 2 foci of capsular invasion, but no vascular invasion. Let me make a comment here that is critical. When you read pathology reports like this, always make sure that your pathologist specifically says that they have sectioned the entire capsule of the nodule. If only part of the capsule has been sectioned, the pathology report is incomplete and you don't know if you're dealing with a cancer or not. I've seen some pathology reports that say representative section of the capsule was studied. Insufficient. Particularly if they say it's positive, there's capsular invasion, then okay, you know it's cancer, but still it is insufficient because it won't give you how many vessels are invaded. So unless you know that the entire capsule was specifically sectioned, then the pathology report is not sufficient, and you have to ask your pathologist to go back and do more work. For a nodule that is 2 centimeters, it's not that bad, but we've seen nodules that are 6, 7, 8 centimeters, and the pathologist has to unfortunately make hundreds of slides to do this. But that's what they have to do. That's the only way to know if this nodule is malignant or benign. So I would like to hear some input from you guys. Let's say we have this patient, it has 2 foci of capsular invasion, and she's had a hemithyroidectomy. Who would recommend anything else? Who would recommend completion thyroidectomy? Who would recommend radioactive iodine? Who would recommend nothing? Who would recommend thyroid hormone? Any comments, any thoughts? Well, I mean, if you look at the available data, a thyroid cancer that is only that has only capsular invasion, a follicular thyroid cancer that has capsular invasion, the risk of metastasis is extremely low to none. So these patients, hemithyroidectomy is more than enough. This woman doesn't need any other kind of treatment, doesn't need completion thyroidectomy or radioactive iodine. The surgery was more than enough to treat her cancer. If the cancer were, with 2 foci of capsular invasion, but it was an 8 centimeter tumor, different discussion because you could easily miss things there. But in this particular case, I think she's fine. I don't think she needs any other surgery or anything else. The question now is obviously, would you put her on thyroid hormone? Would anybody put this woman on thyroid hormone?
No.
I'm sorry, go ahead.
No.
Obviously, it depends on what her TSH is. I would measure her TSH 1 or 2 months after the surgery and see what her TSH is. If her TSH is 1, I would not put her on thyroid hormone. If her TSH is 10, I would definitely put her on thyroid hormone. If her TSH is 3 or 4, I would have a discussion with her. There's a question, obviously, because she has a cancer, should we keep the TSH, closer to the lower part of the normal range? There's no data to suggest that. If her TSH is 2 or 3, I would not necessarily feel the need to put on thyroid hormone. My personal practice is that I tend to put patients like this with these types of cancers. I have a lower threshold. I put more people on thyroid hormone, but I cannot tell you there is data to suggest that. This is my own preference. And because she lost half her thyroid gland, if she told me that she wants to get pregnant, then I would definitely put her on thyroid hormone. But for the most part, I agree with you. I would not. If her TSH comes back as 1 or 2, I don't necessarily feel that I have to put her on thyroid hormone. Any questions?
There is also, sorry. On the second page, there is a comment that she had brain fog.
Yeah, I mean, let's say the assumption on the last paragraph is that you put her on thyroid hormone and she comes in complaining of fatigue and of focus, memory problems, but her TSH is suppressed, her T4 is a little high, is high normal, and her free T4 is high normal, and her T3 is normal. So the question is, what do you tell her? You put her on thyroid hormone, her TSH is now low, but she's complaining of poor memory and lethargy, and she's not feeling well. What would you do? Do you feel the need to keep the TSH low in this case? That's basically the question that we need to ask. We need to answer. Does anybody feel like we need to keep her TSH low?
No, because she's low risk.
Exactly. She's low risk. I don't think we need to keep her TSH low. I would definitely back off on her levothyroxine and to allow the TSH to come back up into the normal range, and tell her that it's certainly possible that she may feel better because she's hyperthyroid. I hope with any luck, she's going to feel better when she becomes euthyroid again. Any other questions? Any other comments?
I have a question back about amiodarone-induced thyroiditis, if that's okay.
Please.
So I was just looking through my chart on the most recent person I had with amiodarone-induced thyroiditis, and I was just looking for some advice in hindsight, as things have normalized now, but it's someone who was diagnosed.
Start over again. You broke up for a second.
Oh, my apologies. I was just looking for some advice in hindsight about someone I treated with amiodarone-induced thyroiditis, that I think I was much slower to normalize their thyroid function than I would have liked.
Okay.
The question I have is, someone had a year of subclinical hyperthyroidism and then was referred to me with overt hyperthyroidism about a year ago. And they had been on amiodarone for a year, but they had actually been off of it for 18 months at the time they presented with overt hyperthyroidism.
Okay.
I did a radioactive iodine uptake and scan that had 0.5% uptake after 26 hours. Which I did not interpret at that time as diagnostic, but in hindsight, I'm wondering if just because it was detectable, I should have thought more type 1 at that time. So I was more suspicious of type 2 because of the timeline and presentation.
I would measure urinary iodine in this case.
Okay, I didn't have that locally available, but for my learning, how would that have, if the iodine was...
If the iodine is still very high, that will help me say it's most likely still not a type 1. And it's that far out. I don't think if the patient has an overproductive state that far out from the amiodarone, I doubt it will be related to the amiodarone. It will most likely be autonomous Graves. Did you have antibodies?
I did. They were negative.
Okay.
I'm
sorry, go ahead.
Oh, sorry. I was going to say clinical exam of their thyroid was unremarkable as well. And I did have an ultrasound that showed no nodules and no goiter.
How about flow? Was there any increased flow?
I don't have expertise really available for Doppler on ultrasound, so there was no comment.
Okay.
So I started them on prednisone, I think 40 milligrams, which was a dose sort of in between 0.5 and 1 milligrams per day. And after I think 2 months or so, the TSH remained completely suppressed, but the free T3 and free T4 were within normal limits. When I started a prednisone taper, though, around the 2.5 month mark, because the free T4 and free T3 remained within normal limits, they got worse. So at that point, I started methimazole as well, wondering if I had a mixed picture. And then it sort of took 5 months or so, and then things sort of all of a sudden normalized. But I only started them on methimazole 10 BID. So I was wondering if in hindsight, I should have, I don't know, used higher doses.
I mean, you most likely were still dealing with amiodarone-induced hyperthyroidism. It's highly unlikely, highly unusual that 18 months after stopping the amiodarone, you'll still get a type 1. But you certainly were dealing with a thyroid gland that was saturated with iodine and was in an overproductive state. That's what it sounds like. And that's where, the urinary iodine would have been of great help to you. But I mean, yeah, there was no way for you to know. I would the only thing that I would do in this case is I would follow the thyroid function test every 2 or 3 weeks and decide and make adjustments at that frequency. I would not wait for 3 months or 5 months to repeat the thyroid function test. And
I was following it, every 2 weeks.
Yeah. If I didn't see improvement after a while, I would, in hindsight, hindsight is very important. in this case, I would have probably increased the dose, but I agree with you. Those are very difficult, challenging cases.
Okay. Okay. Thank you. Appreciate your help.
So there's a couple of other comments in the section. If the TSH is low, could goiter itself be increasing the uptake? The answer is yes. If there's autonomous nodules, even in the absence of TSH, these nodules take up iodine. They have autonomous nodules, for example, often have TSH mutations, activating TSH receptor mutations, which means that the TSH receptor is constitutively active. So it takes up iodine even in the absence of TSH. So yes, absolutely. If a nodule is ThyroIdeS 5 and benign, would you repeat the biopsy or follow with ultrasound in 6 months? That's a very difficult question. The first thing you have to answer in this case is to try to figure out if if you trust your radiologist. If the ThyroIdeS is a true ThyroIdeS 5, then I would follow this nodule very carefully. Or I've had cases where I actually repeated the biopsy, and I've had one case where I sent the patient to surgery. The biopsy was consistently benign, and this turned out to be a cancer. Very rare situation. So if it's a true ThyroIdeS 5 nodule, I would be very, very careful. But you have to have very high confidence in your radiologist. Even at Mass General, I see it very frequently. Nodules described as highly suspicious, and they're even spongiform. So as long as you trust your radiologist, I would definitely be very worried about this nodule if it's a true ThyroIdeS 5 nodule, and consider either repeating the biopsy, and depending on the situation, even going to surgery. But again, those are very rare. But at least I would follow it very carefully every 6 months for sure. I would not wait a year or 2 years. But this is where you need to actually trust your radiologist really, really well before you can make that determination.
Sorry, doctor, I have a quick question.
Yes.
In the workup of thyrotoxic patients, sometimes the consultant requests T3 level.
Yes.
How does it help, and does it really differentiate among the different causes?
Absolutely. There are, as we talked about before, there are some cases. First of all, what I'd like you to think about when you think about hyperthyroidism, I'd like you to separate it into two groups: the overproductive state and the destructive state. The overproductive state is the Graves' disease and the toxic nodules, and destructive states are thyroiditis. The thyroid gland mostly stores thyroid hormone in the form of T4. So if you have a destructive process, you're going to have what we call a T4 dominant thyrotoxicosis. The T4 goes up a lot more than the T3. In the overproductive states, somehow, for some reason, the machinery changes, and the thyroid gland starts pumping out a lot more T3. So the overproductive states, Graves' disease, toxic nodules, tend to be a more T3 dominant picture. So there are studies that looked at the ratio of T4 to T3 that help you decide if it's a destructive versus a overproductive state. Not very good data, but it's certainly there. But there are some very rare cases, as we talked about, of what we call pure T3 toxicosis, where if you do a thyroid function test, if you're going to see a fully suppressed TSH, but a normal T4, and you're going to say, okay, this is mild subclinical hyperthyroidism, but if you measure the T3, it's very high, it's through the roof. So without measuring the T3, you can miss some severe cases of hyperthyroidism in cases like that. So whenever you're dealing with hyperthyroidism, measuring the T3 is critical in all cases.
And what is the ratio, please?
It depends on the units you use. Different studies use different units. But for the most common units, I think the ratio used is about 20. But it depends on your lab. It depends on what units you're using. So I cannot give you, I don't know exactly what the ratio will be for your lab, for your units. But again, this ratio, you can use it as a guidance, but it doesn't always distinguish between the two. So it's not 100%. So don't depend on it. Don't depend just on it, just on the ratio. It's never been shown to be that effective.
And in a normal person, what is the ratio?
A normal thyroid gland mostly makes 90% of what a thyroid gland makes is T4, and maybe 10% is T3.
Yes.
But most of the T3 in the circulation doesn't come from the thyroid gland. It comes from the peripheral conversion of T4 to T3 in the liver and the muscles.
Last comment, please, about the last case where the patient had this brain fog, memory issues. I mean, it sounds more towards hypothyroidism rather than hypo rather than hyper, but the TSH was suppressed. So, I mean, can you comment on that, please?
I'm sorry, repeat your question. I didn't understand what you said.
The last comment for the case where this patient had memory fog and concentration fatigue, it sounds more towards hypothyroid symptoms, but the TSH was suppressed and we said it's more like hyperthyroid. I mean, can discordant, sorry?
Yes, the best answer that I can give you on that is sometimes the patients don't read the textbook before they develop symptoms.
Thank you, doctor. Thank you so much.
You understand what I mean, right?
Yeah, I do, yes.
What I tell them in this case is this, and your symptoms are very difficult to interpret. Let's get your thyroid hormone function test into the normal range. Let's see how you feel. Let's assess the situation with you having normal thyroid function test, and then we can decide what to do with your symptoms.
Exactly. Thank you so much for your time and expertise.
There are two comments. Are you more aggressive in the follow-up of oncocytic thyroid cancer for imaging, even if TG is negative? That's a difficult question. You have to be more careful because you're right. You may have thyroglobulin may not be as predictable as helpful in cases of oncocytic thyroid cancers. But it depends. If I have a 1.5 centimeter oncocytic thyroid cancer that was removed and nothing has happened, then I'm not too worried about them. But if I have an 8 centimeter purple cancer, then yes, I'm very worried about them, and I would be more careful following them. But in general, you are correct. I am more worried about the oncocytic ones because they don't respond to the radioactive iodine too. If TSH is suppressed and 3T4 and 3T3 are normal, no nodule and no Graves' disease, however, they have a goiter and uptake is slightly high, and someone says, would you treat? Okay, suppressed TSH, normal 3T4, normal 3T3, no nodules, and the uptake is slightly high. That, by definition, my friend, is Graves. When you say no Graves' disease, I'm assuming you mean no Graves' antibodies. That patient, the patient you're describing, has Graves' disease. Even if they don't have the antibodies, if they have a suppressed TSH, a normal T4, normal T3, and a high uptake on the scan, that by definition is Graves' disease. So yes, I will treat them. If they're over 65, they are at risk of developing atrial fibrillation and osteoporosis. So I will definitely treat those. Now you've diagnosed the patient with Graves' disease.
Sorry, doctor, in this last case, the patient underwent hemithyroidectomy for the follicular cancer.
Yes.
So can we do suppressive TSH for a patient with hemithyroidectomy?
Okay, of course, is it possible? Yes, if you give enough levothyroxine, we will suppress them. Should we do it? The answer is absolutely not. I agree with you. We should not do it. But if you give enough thyroid hormone, you're going to suppress the TSH, as you know. But we should not do it. But is it possible to do? Sure, it is. I mean, if you give enough levothyroxine, you can suppress the TSH on anybody. But we should not be doing it, though. I agree with you. Thank you, everybody. Thank you for participating in the discussion. It was a very good discussion, I think. Please send your comments if you think we need to do this any differently. If you have any suggestions, always happy to take comments. And thank you for joining us today.
Thank you so much. Thank you very much.